In our last video, we learned about JCC, what it is, how it looks, and the basic concept behind it. But here is what most of us struggle with. Initially, we understand the theory, but the moment we pick up the JCC in real refraction, we'll just freeze. Like, which do I check first? And which direction I should rotate? And what do I do if my patient keeps saying both options looks the same? And most importantly, when I have to do the JCC procedure. So today I'm going to answer all of these questions. This is going to be a complete JCC procedure step by step with some clinical tips, and also we are going to address the common mistakes to avoid during JCC. Before we get into the procedure, let me quickly recap what we covered in the last video. JCC is a spherocylindrical lens which has an equal and opposite cylindrical power on two perpendicular axes. The most common one we will use is plus or minus 0.25 diopter JCC, which has the power of plus 0.25 diopter sphere combined with minus 0.50 diopter cylinder. It has a handle. That handle is placed at 45 degree between the two principal meridians. Here you can see the two dot, red dot marking the minus cylinder axis and the black dot marking the plus cylinder axis. This has two uses in refraction. Number one, to refine the axis of cylinder. Number two, to refine the power of cylinder. And one critical rule before we go further, JCC is always used after your retinoscopy or your autorefractor has already given you an initial cylinder. You must have a starting point. JCC refines that starting point. It does not create it. Before you flip the JCC even once, you need to set up correctly. Let me tell you how exactly what the patient and the trial frame should look like before you start. Step 1. Your patient is seated comfortably. Both eyes are open, but you are testing monocularly. So, occlude the non-testing eye. Step 2. Place your best corrector sphere in the trial frame. You should have already done your maximum plus 2 maximum visual acuity before picking the JCC. If you haven't done that, go back and do it first. Step 3. Your initial cylinder. The axis and the power from your retinoscopy or from your AR. That should already be in the trial frame. Step 4. Choose your target letter on Snellen chart. Use a letter approximately 612 or 69, 1 or 2 lines above the patient visual acuity. You may think, why not the smallest line they can read? The reason is, when you flip the JCC, you are deliberately blurring one meridian. If you start with the smallest letter, the patient can't make a reliable comparison. You want them to see clear enough to judge between two slightly different options. Step 5. Tell the patient exactly what you are about to do. You can say something like, I am going to show you two options. I'll call them position 1 and position 2. Neither will look perfect, but I want you to tell me which one looks slightly clearer. This instruction is so important because sometimes patients might get anxious when both options look similar. If you don't want them before, they will give you answer like, I don't know. Then your whole test will break down. So be careful with your clear instructions. Let's start with the axis refinement. This is always done first, before power. Remember that axis first, then the power. The axis determines the orientation of your cylinder. If your axis is wrong, your power refinement will also be inaccurate. So we always confirm the axis first. Place the JCC so that its handle is aligned with the cylinder axis in the trial frame. I say that again, the handle goes on the cylinder axis, directly on it. When the handle is on the axis, that means the two principal meridian of JCC are sitting at 45 degrees on either side of your cylinder axis, which is exactly the position that allows you to test whether the axis should rotate clockwise or counterclockwise. You show the patient position 1 Note which way the red dot are oriented. Then you flip the JCC to position 2. Now the red and white dot have swapped sides. You ask the patient which is clearer, position 1 or position 2. Rule number 1, if your patient says position 1 is clear, you rotate the cylinder towards the red dot, the minus axis dot in position 1. Rule number 2, if the patient says position 2 is clearer, you rotate the cylinder axis again towards the red dot in position 2. Rule number 3, if the patient says both look equal, your axis is correct. You can stop rotating and move on to the next one. Now, how much do you rotate? When you are far from endpoint, meaning the patient is clearly preferring one position, rotate by 10 degrees. As you get closer to the endpoint, the patient preference is less strong. Reduce to 5 degree steps. In final step, move only 2 to 3 degrees at the time. Keep flipping and rotating until the patient consistently say both positions look equal. That is your refined axis. Now let me tell you the common mistake during axis refinement. Rotating in wrong direction. This happens because we might not sure which dot is the red dot in the current position. So here is my tip. Before you start, hold the JCC up and look at it. In position 1, identify where the red dot is. Write it down if you need to. Then in position 2, identify where it is again. The rule is simple. Always move towards the minus axis of the preferred position. If the patient prefers position 1, you move towards the red dot as it appeared in position 1. Also, another mistake, over-rotating. You make a large rotation, the patient now prefers the other side. You overcorrect again and you end up going back and forth without even converging. Keep your steps small as you approach the endpoint. Power refinement comes after axis refinement. Do not do this in the wrong order. For power check, you change the position of the JCC. Now, instead of the handle sitting on the cylinder axis, you place the handle at 45 degree to the cylinder axis. When the handle is at 45 degree, the principal meridian of the JCC align directly with the principal meridian of the cylinder in the trial frame. This allows you to test whether the cylinder power needs to be increased or decreased. Now flip the JCC and ask the same question, position 1 or position 2. If position 1 is clear and in position 1 the minus axis of the JCC is aligned with the cylinder axis in the trial frame, this means the patient prefers more minus. So you increase the minus cylinder by 0.25. If position 2 is clear, meaning the plus axis of the JCC aligns with the cylinder axis, the patient prefers less minus. So you decrease the minus cylinder by 0.25. If both are equal, the cylinder power is correct. Every time you change the cylinder power, you must adjust the spear to maintain the circle of least confusion. Let me explain quickly. When you increase the minus cylinder by 0.50 diopter, you have shifted the circle of least confusion. To bring it back to the retina, you compensate with minus 0.25 in the spear. Similarly, when you decrease the minus cylinder by 0.50, you add 0.25 to the spear. If you don't do this, your final spear will be off and your patient overall visual acuity will be worse than it should be. Continue flipping and adjusting in 0.25 diopter cylinder steps until the patient says both positions look equal. Once you have that, your cylinder power is confirmed. Now let's talk about when you should reach for JCC and when you should not. Number 1, cylinder has already been detected. Your retinoscopy, keratometry or autorefractor has given you a starting cylinder value. You are using JCC to make that value more precise for the patient's subjective experience. Number 2, you are performing subjective refraction. JCC is a subjective technique. The patient's response guide every decision, so the patient must be cooperative, alert and be able to give reliable responses. Number 3, after maximum plus to maximum visual acuity. You must have your sphere optimized first. If the sphere is wrong, the JCC will give you unreliable result because the circle of least confusion is not in the right position. When JCC should not be used. Number 1, the patient has low vision or poor visual acuity. They cannot reliably compare two blurred options. Number 2, the patient has poor concentration. Very young children or elderly patients who fatigue quickly. You will get inconsistent response and test becomes meaningless. Number 3, the media opacity, dense cataract and corneal scar. And when you get an oblique astigmatism, meaning the axis at 45 degree or 135 degrees, you need to be extra careful with your rotation direction. The axis transition can be confusing in these cases. So go slowly and double check your movements. Axis 90 and 180 are most common astigmatism axis. With this, the rotation direction is straightforward, but oblique axis require more attention. So how do you know you have truly achieved the endpoint? The patient should consistently say across 2 or 3 flips in a row that both positions looks equal, not just once. If they say equal once and then prefer one side again, you haven't reached the true endpoint. So keep going. Once you have confirmed the axis and the power, do this. Number 1, remove the JCC from the trial frame. Number 2, recheck the visual acuity. Number 3, if the visual acuity hasn't improved and the cylinder value have changed significantly from your initial finding, consider going back and recheck. After JCC, your next step is binocular balancing, making sure both eyes are fogged equally before you do the binocular endpoint. So let me give you the complete summary of this video. Step 1, complete your maximum plus to maximum visual acuity first. Step 2, axis refinement. Step 3, power refinement. Step 4, remove JCC and recheck visual acuity. Use JCC only after initial astigmatism is detected. Use it when the patient can give reliable responses, and be careful with your oblique astigmatism patients. Never forget your sphere compensation rule. So that's all about the JCC procedure. If you like this video, share, like and subscribe to Optom. I'll see you in the next video.